This video will do a shallow dive and briefly cover urticaria, commonly referred to as hives. Urticaria is a kind of skin rash with red, raised, itchy bumps that are caused by IgE and non-IgE mediated mast cells and basophil release of histamine and other inflammatory mediators. It is characterized by wheals, angioedema, or both. A wheal is a central area of swelling surrounded by erythema that is temporary and generally returns to normal in less than 24 hours. Angioedema is generally a bit slower to return to normal, taking up to 3 days. A wheal is typically 1 to 2 centimeters in diameter, but can vary in size, it can grow, and also coalesce with other wheals. Any area of the body may be affected, although areas in which skin rubs together, like the armpits or knees, or areas where clothing compresses the skin, are sometimes more affected. Urticaria affects 20% of people at some point in their life. Avoidance of triggers is key to managing urticaria, but it is much harder to identify triggers in chronic urticaria. So, a thorough investigation should be done in patients with acute urticaria to minimize risk of progression to chronic urticaria. Most cases will resolve on their own, and they do so within 6 weeks. So, urticaria that has been going on for less than 6 weeks is categorized as acute, and urticaria lasting longer than 6 weeks is chronic. It is important to assess clinical clues in the patient history or symptomology to help identify the cause. This table lists several clinical clues that may be helpful in identifying the possible etiology in patients with acute urticaria. Most food allergy reactions happen within 30 minutes of ingestion, so it would be food eaten very recently, not just within the past few days. Assessment for urticaria mainly revolves around physical examination and obtaining a detailed and accurate patient history. Labs are not routinely ordered and are not cost-effective. Sometimes, in refractory urticaria that has become chronic, or there are the presence of other red flags which may warrant investigation for other diseases, a CBC with a white blood cell differential, an ESR or erythrocyte sedimentation rate, or thyroid function tests may be ordered. If the white blood cell count differential shows eosinophilia, that may raise concern for a parasitic disease, and further investigation may be warranted. An elevated ESR may indicate a more systematic disease such as SLE or urticarial vasculitis. So all dermatology topics have pictures to help with identification, so here are a few urticaria examples. The first is urticaria after exposure to cold temperature. Secondly, you will see this is an urticarial drug eruption. And lastly, please note that urticarial lesions are generally raised like in this picture. However, they may be flattened in patients who are already taking antihistamines. Interleukin is more responsible for wheals, whereas bradykinin is more responsible for angioedema, and histamine plays a role in both. When it comes to guidelines for treating urticaria, you have 3 options as listed here. There are many causes of urticaria, including infections, cold, contact allergens, insects, and several medications, including antibiotics, NSAIDs, opioids, and contrast agents. There are many more less common causes not listed here. Viral infections, food, and drugs are the most common causes, accounting for maybe up to 25% of cases. NSAIDs, in addition, may worsen chronic urticaria in up to 30% or more of cases. Some non-pharmacologic measures may also be recommended to help patients cope with symptoms. When the urticaria is at its itchiest, frequent lukewarm showers may be helpful. Showers that are too hot or too cold can make it worse. Soothing lotions and emollients can provide some relief as well. The patients should avoid perfumes containing alcohol or other substances that can irritate and make the urticaria worse. Laundry detergent can cause dermatitis, but it is not shown to cause or worsen urticaria. Some patients may think changing laundry detergents may help, but there is no evidence to support this practice. Food and symptom diaries can help with identifying substances or activities that make urticaria worse. A psychological exam may also be beneficial, as there is a high prevalence of psychological symptoms in patients with urticaria. The unanimous first-line choice among all guidelines are the second-generation antihistamines, such as cetirizine or loratadine or many of the others. These drugs are preferred over first-generation antihistamines for many reasons, including significantly less sedation. They are free of anticholinergic effects that can complicate the use of the first-gen agents. They require less frequent dosing compared with the first-generation agents, and they have fewer significant drug-drug interactions. First-generation antihistamines cause sedation and performance impairment in over 20% of patients. The sedative effects of the first-generation antihistamines last around 12 hours, whereas the antipyretic effects last only 4 to 6 hours. This all explains why these second-generation agents are always preferred over the first-generation agents, including in special populations such as pregnancy and pediatrics down to 6 months old. However, in pediatrics, the dosing would change, as you would use a weight-based dosing for the second-generation antihistamines. All three guidelines recommend a second-line option of dose escalation of up to 4 times the normal dose for these medications. However, some physicians may be hesitant of using such high doses. The other second-line option would be to add an H2 blocker such as famotidine or ranitidine. Second-line agents should be tried after 2 weeks where the first-line treatment has not met the goal of complete symptomatic resolution. Third-line options include corticosteroids or montelukast more commonly. More rare options are tranexamic acid, omalizumab, or other immunosuppressants. Montelukast is more effective in patients with cold-induced or NSAID-induced urticaria. Tranexamic acid helps treat the angioedema as it decreases bradykinin levels. You would not use tranexamic acid in patients without angioedema. That concludes this brief overview of urticaria. Thank you for your time and attention.